Amay Patwardhan, who is assistant professor in geriatric medicine at the University of Western Ontario. And he's got so many laurels, including the clinical and academic focus on cognitive neurology, neurodegenerative disorders, dementia, movement disorders. He's a alumni of NIMHANS India, and he's got a fellowship in cognitive and movement disorder from University of Toronto, as well as dementia and neurodegeneration from the Western University. Currently, he is assistant professor, Division of Geriatric Medicine and Division of Neurology, Western University. He has got a number of publications, including first author in national and international journals in stroke, Journal of Prevention of Alzheimer's disease, and of course, Canadian Journal of Neurological Sciences. So over to you, Dr. Ame. Uh, be the first honorable speaker on this webinar. Over to you.
Thank you very much for the kind introduction. And it's indeed a pleasure, and it's a big moment for me to inaugurate this webinar series. Let me share my screen to present my slides. Just checking if the presentation is visible.
Not yet.
Not yet. Okay, let me try again. How about now?
Yes, it is visible. Please go ahead.
Okay, great. Thank you so much. So today I'll be discussing two important conditions that present in late life, that is Alzheimer's disease and normal pressure hydrocephalus. And we know that NPH has for long been conceptualized as a form of treatable dementia. Although I'll paraphrase that and say it's a treatable disorder, at least partially, because we know that the dementia component of NPH may not improve, but it's the gait component that really improves with a ventriculoperitoneal shunt. So it's a treatable disorder. And as we know, the exact cause of NPH, we still don't know, and the prefix idiopathic still remains stubbornly attached. About Alzheimer's disease, it needs no introduction. It's the most common cause of dementia in older individuals. So today what we are going to see is, are there imaging differences that can help us in differentiating between these two conditions? Are there areas of overlap that may contribute to diagnostic uncertainty? And then we'll also discuss how these overlapping features and distinct findings can help us and influence our clinical decision making and management strategies. As we explore this topic, we'll try to we'll try to explore if these two disorders are completely distinct, as in, if you imagine the blue circle as Alzheimer's and the red circle as NPH, are they totally mutually exclusive entities? Is the overlap between these two disorders purely by chance alone? Or do they interact with each other in such a way that the overlap is more significant and more than what we can expect by chance? Or are they two different forms of the same disorder, in fact? So these are the four possibilities that we'll explore going forward. And when it comes to treatment, we know that the treatment options are entirely different between the two conditions. So NPH, we know the classical treatment is ventricular shunting, most commonly ventricular peritoneal shunting, and Alzheimer's disease has a completely different management. And therefore, it becomes really important to distinguish or to arrive at the diagnosis correctly, and that would be the first most important step in making the management plan for these conditions. So if we ask what is the efficacy of ventricular shunting for NPH, like is shunting really effective? And the short answer is yes. That's a grade 1 recommendation, level of evidence B. Until now, there was no randomized controlled trial in this field. However, in late 2025, in October, the first RCT on NPH, that is shunt versus no shunt, was published in JAMA Neurology. And it indeed showed that, yes, among participants with NPH who had a response to temporary CSF drainage, shunting indeed resulted in improvements at 3 months in the gait velocity and measures of gait and balance. So, yes, now we have conclusive evidence that shunting works for NPH, but there are some caveats there. So, shunting does not improve measures of cognition and it did not improve measures of urinary incontinence. And therefore, I said NPH is at least partially treatable. It's important to set realistic expectations, and especially the dementia component of NPH may not improve or may not respond to CSF shunting. How safe is this shunt? So we know this is a major neurosurgery. We are putting a shunt in the ventricle and then diverting the fluid to the abdominal space. And so this is a major neurosurgery, and it carries a risk of hemorrhage, it carries a risk of infections, especially in people who have comorbidities, it can be unsafe. And therefore, this is one of the more recent studies that I've shown on the slide from the Adult Hydrocephalus Network in Calgary, which is a leading NPH program there. And they published data recently to show that the safety of shunt surgery has improved over the years. So there was a very high complication rate relating to unprogrammed or non-programmable valves and relating to shunt infection and hemorrhage, which has now subsequently reduced with surgical advances. And of the 193 patients that were reported in this study, 91% did not have any complications. So they had a really good safety profile. And of the few patients that had complications, only 6% had serious complications that needed a shunt revision, and there were no deaths reported. So that's a really promising thing for the NPH field. However, we know that it's still a major surgery, and in this unfortunate patient that I've showed on the slide, we can see a very large intracerebral hematoma in the left ventricle, and so really in some people it can be dangerous, and therefore we really want to. Our goal would be how can we maximize the benefit of shunting in people who are good surgical candidates, and how do we avoid potential harm in whom we should be leaving them alone, in whom shunting is contraindicated. So how do we make, or how do we arrive at this pre-surgical selection? It is a very challenging field, and there are so many. It's riddled with a number of diagnostic challenges. There are many surgical unknowns as well, and it- like going through all of those would be, of course, beyond today's focus. But today we'll be talking about one of these determinants, the one on the lower left, which is common co-pathologies or common degenerative pathologies or misdiagnosis. So this really influences our decision making and management. And today we'll be focusing on this challenge, the presence of neurodegenerative disorders, which can also inform the prognosis. So that would be the focus of today's talk. Before we go into the interaction of Alzheimer's and NPH, let's briefly have a brief recap about what are the diagnostic criteria for NPH. And as most of us would be aware, there are two sets of guidelines. We know that there were the international guidelines that came out first in the year 2005, and subsequently there came the Japanese guidelines, which have had a couple of revisions. The core feature of both of these criteria would be the clinical triad. And as we are aware, the clinical triad of NPH is gait disturbance, cognitive impairment, and urinary incontinence. We know that not all patients are going to present with the triad. And we know that cognitive impairment is the common factor between Alzheimer's and NPH, which often results in a clinical dilemma between what the correct diagnosis is. So the international guidelines say there should be at least one symptom of the triad present, and the Japanese guidelines say at least two of the three of the triad symptoms be present. Further, in terms of brain imaging, the other common factor between Alzheimer's and NPH is ventriculomegaly. So both of these disorders can cause big ventricles or expansion of the ventricular size. And as we know, the ventricular size is measured by the Evans index, EI, which if it is greater than 0.3, it indicates the presence of hydrocephalus. Now, it's important to bear in mind that this hydrocephalus is non-specific. So it may be due to any causes. It may be secondary to brain atrophy, in which case we call it hydrocephalus ex vacuo, which is the more common finding of Alzheimer's. And then in NPH, there is disproportionate enlargement of the ventricles compared to the cortical atrophy. So elevated Evans index would just be non-specific hydrocephalus, and it would include both the conditions. So that doesn't necessarily help us narrow down between NPH versus Alzheimer's. So what are some of these additional neuroimaging components that we can use to then further delineate the diagnosis? So the international guidelines mention a narrow callosal angle, which, if below 90 degrees, that would be supportive of NPH. Similarly, in the Japanese guidelines, there is a lot of emphasis on the phenomenon of DESH or DESH, which is also called disproportionately enlarged subarachnoid space hydrocephalus. And we know DESH is a central concept of NPH that has a lot of importance in the Japanese guidelines. What DESH means is that there is crowding of the sulci at the vertex of the brain. And this crowding leads to disproportionate enlargement of the infratentorial or the sulci lower down in the brain, whereas the sulci at vertex are very tight and there's tightness at the high convexity. And this disproportion is called as DESH. Now, it's again important to remember DESH is thought to be a very specific finding of NPH, but not all patients with NPH will have DESH related features. So, certainly, when DESH is present, we are more convinced about the NPH diagnosis as compared to Alzheimer's. And in the further slides, we'll look at some images to better conceptualize these features. And lastly, NPH and Alzheimer's both are chronic conditions. So in none of these conditions, this ventricular expansion has developed acutely. So in both of these, they appear in late life, their prevalence increases with age, and they are chronic, they are slowly progressive. So if it is acute hydrocephalus, it is almost never due to NPH or Alzheimer's. It has to be due to a secondary cause. Also, because of its chronic, slowly progressive nature, the other important finding is that CSF pressures remain low to very mildly elevated. So it does not result in increase in the intracranial pressure. So these are some of the essential findings, and this is something that's already known and that's already published in the literature. Here are some slides, some images to better conceptualize the NPH findings. And both of these panels, the top panel and the bottom panel, we are seeing some classical features of NPH. So if you look at the top left slide in the panel A, we can see the Evans index being shown there, where we can see it's the ratio of the highest diameter of the frontal horns of the lateral ventricle to the highest diameter of the inner table of the skull. And we can see how this is more than 0.3. In the middle image on the top panel, we can see some focally enlarged sulci. So there are pockets of CSF that are enlarged, and the yellow arrow in the top right shows that high convexity tightness. So we can see that the sulci in this part are not at all visible, whereas sulci in the other parts of the brain are visible. So this indicates tightness at the vertex. Let's look at the panel below. We can see the enlarged lateral ventricle in this sagittal view, and we can see how it has thinned out the corpus callosum as indicated by the blue arrow. And we can see how the green arrow shows fluid pockets or fluid enlargement in the calcarean fissure of the brain. So we can see these focally dilated sulci and CSF outpouchings. And we can see how this high convexity tightness, look at the bottom panel on the rightmost image there, we can see the acute callosal angle. And that's because of these sulci at the vertex being very tight. We can see this crowding of the sulci there, causing a very acute callosal angle. And we can see the sylvian fissures in the bottom are, however, much more dilated. So this is the typical finding of DESH that I referred to. If it was this easy and if all patients presented in this way, it would have been much easier in real life. However, in real practice, in real life practice, there are many more overlap findings, and findings are not as straightforward as are shown in this picture. So not all patients follow the textbook, and therefore we land into situations where there can be some clinical dilemma in the diagnosis. Let's look at the next slide, where we can see how NPH features can be differentiated from Alzheimer's disease. And the top panel here represents NPH, which I described already as elevated Evans index, high convexity tightness in the image B. And in the image C, we can see the acute callosal angle. Compare this top panel to the bottom panel. The bottom panel of this image shows Alzheimer's disease findings. and we can see how there's uniform atrophy of all regions of the brain. And because of this, there is no tightness of the high convexity. If you look at the middle image on the bottom panel, we can see that the sulci are dilated all across the brain. And because of this uniform dilation, we can see that in the bottom right image, you can see how the callosal angle is wide or more than 90 degrees. That's because the corpus callosum is uniformly stretched, and that's because of the cerebral atrophy. So even though both these disorders, as we can see, have an elevated Evans index or hydrocephalus, the cause of the hydrocephalus and the mechanism of the hydrocephalus is different, and therefore we can aim to differentiate between these two findings. So the focus so far was on how do we differentiate or how do we separate Alzheimer's from NPH? Can we separate them so that we can uh, proceed along the lines of NPH management for the NPH cases and proceed along the lines of Alzheimer's management for the Alzheimer's cases? So again, if this distinction is clear cut, it would have been easy. However, very often we see some mixed findings, which we'll talk about very soon. If we look at this differentiation, we know that Evans index is very sensitive, but it would capture a lot of non-NPH cases also. So there would be a lot of false positives on that spectrum. And if we incorporate the callosal angle, that makes it a little more specific. So Evans index plus acute callosal angle would then make it very likely to be NPH. And then if there is the presence of DESH, then that would make it even more specific. However, if we just included patients with DESH alone, then it would also likely miss some of the cases that were NPH, and therefore it would be increasing specificity at the cost of reducing the sensitivity. And so there's this whole spectrum, and the challenge is if we use criteria that are too specific for NPH, then we are at a risk of excluding some cases that may not have those specific features. If we use radiological criteria that are too broad, like just using the Evans index, then it would likely capture a lot of false positive cases. And that's where the clinical confusion and the radiological dilemma lies. Let's look at this. So this slide here, this flow diagram shows the recommendation issued by the Movement Disorder Society. So what are the MDS guidelines? What is the minimum type of workup that we should do whenever someone with suspected NPH comes to us? And so there are three important pillars. One is we want to do cognitive testing for all these patients. And ideally, we know that in NPH, there can be a frontal subcortical kind of dysfunction. So there can be reduced attention, reduced executive function, and processing speed. However, typically, like in the ideal case scenario, their memory, short-term memory, and visuospatial functions, so other cortical domains, should be preserved. And in case you get some short-term memory deficits, or you get visuospatial dysfunction, then that would be a red flag as to a cortical dementia rather than a subcortical dementia, which we see in NPH. The second part of the basic workup would be a thorough neurological examination. So ideally, we know that the gait features of NPH are the highest level of gait disorder. So people would have a very slow gait with short steps. There can be freezing of gait. There can be lot of freezing. There can be difficulty making turns, and there can be difficulty in gait initiation. However, typically their arm swing is normal, and they do not have other. They should not have ideally other features like a neuropathy or upper motor neuron weakness or spasticity or any other Parkinsonian features that can explain the gait impairment. And so the gait examination would be a very important first step in evaluating someone with suspected NPH. Ideally, we should do a formal gait assessment with a timed up and go or a 10-meter or 15-meter walk test and measure the gait velocity, which is very reduced in NPH. After that, the other basic element of NPH workup would be to drain the CSF either via high volume lumbar puncture or an external lumbar drain. So temporarily drain the CSF to see if that decompression of the ventricle temporarily improves some of the gait parameters. And again, there's no consensus about what percentage of improvement is acceptable or not. It depends on whether we are using strict criteria. So some research criteria say there should be at least 20% or at least 25% improvement in the velocity. Some investigators accept even a 10% improvement in the gait velocity. So the repeat gait examination is really important. And on the repeat gait exam, also there's uncertainty about the timing of the repeat gait exam. So do we do it 1 hour post tap? Do we do it 4 hours? Do we do it 24 hours after the tap? And ideally, multiple post-TAP assessments are important. Uh, some people have a delayed improvement, so they may not improve at 1 hour and 4 hours. They may improve the next day. And so, to capture those delayed improvements, the 24-hour and sometimes even day four assessment post CSF removal can be important. So, this would be the basic pre-surgical workup for anyone who comes with suspected NPH. So I'll pause at this point and I'll quickly summarize. So we have established that in a subset of patients who present with NPH, especially with gait problems, it is important to do a workup to see if they may respond to a shunt. And that workup would include a cognitive test, a gait exam, a neurological exam, and then a CSF lumbar drain or lumbar puncture with a high volume CSF tap to see if their gait improves post the tap test. So that is the basic thing. Uh, However, the next most important question and very clinically important question is, how are there any reliable indicators or biomarkers of this surgical outcome, of a good surgical outcome? And if we are committing a person to surgery, the patient may ask, doctor, how long is the shunt going to work? So is the surgery going to, is the effect going to last for 3 months? Is the effect going to last for 1 year? Is the effect going to last for 5 years? So really the duration of the response is a really important clinical variable, and we don't have good answers for this. And I think this is where this comorbid degenerative pathology like Alzheimer's comes into the picture. So for example, the hypothesis is that if a person has additional Alzheimer's in addition to the NPH, at some point of time their Alzheimer's disease will progress and then take over all the clinical features, and then the shunt will become useless. And therefore, it becomes really important clinically to detect the presence of this additional Alzheimer's pathology, and that can inform our clinical, it can help us prognosticate the patients better. So, although there, and we'll see a few studies that support this notion. So, the question I'm highlighting here is, do we think, do we think there is merit in pursuing biomarker-based Alzheimer's disease diagnosis prior to shunting an NPH? So before we commit a person with probable NPH to a CSF shunt, which is a major surgery, do we think it can be clinically important to get biomarkers of Alzheimer's disease? So that's the essential question that I'm asking. And let's look at how we can go about answering this question. So, what are the tools we have in hand? How can we detect this comorbid Alzheimer's disease? So, the earliest studies, say 20 years ago, that is the pre biomarker era, were based on brain biopsy. So at the time, fluid biomarkers of Alzheimer's were not available. And therefore, what they did was when they put a shunt through the frontal lobe into the frontal horn of the lateral ventricle, they took a small piece of the brain out and then subjected that piece to histopathological examination for Alzheimer's changes. And therefore, that would be a brain biopsy based diagnosis, which was the older studies in the literature. Then comes amyloid PET scan, and we know that amyloid PET is one of the most definitive ways of diagnosing biomarker-based diagnosis of Alzheimer's disease. The disadvantage of amyloid PET is that it is very restricted in availability, so very few academic centers are going to have it. And so, although it is the most ideal way or the most accurate way, I will say, it's going to be limited in availability. Very few people we cannot use it routinely for all suspected NPH patients. So then comes this third biomarker called CSF biomarkers of Alzheimer's disease. And why I've highlighted this is I think this is one of the most important biomarkers to consider, particularly because CSF testing is already a part of NPH workup. So we already have a high volume of CSF that we drain using the lumbar tap test. So now with this 30 to 40 ml of CSF, why don't we use that as a resource and subject that to biomarkers of amyloid and tau pathology? So because we already have this test as a part of the routine diagnostic paradigm of NPH. And that's why I think this CSF biomarker is very appealing. And then finally, we'll also browse briefly about postmortem diagnosis. So what have we learned from the postmortem diagnosis of cases that had clinical NPH in life, and what did their autopsy findings show? So these would be really the tools that we have in hand to diagnose comorbid Alzheimer's. Let's start with the CSF biomarkers because they are most relevant. So The question I will ask is, what happens to amyloid beta 42, that is amyloid monomer in CSF in NPH? So, what happens to this biomarker? Is it increased, is it decreased, or is it normal? So, those are the three possibilities. I will first discuss what happens in Alzheimer's disease. So we know that in Alzheimer's, because amyloid gets bound into plaques in the brain, so there's amyloid plaques and tau tangles. We know that amyloid monomers are consumed, they form oligomers, and then they polymerize to form amyloid plaques, which are insoluble. And as that happens, the levels of the monomeric amyloid fragments go down in the spinal fluid. So what happens is it's a consumptive process. And so all the amyloid gets bound up in the plaque monomers, and its levels in the CSF go down. So that's what happens in Alzheimer's disease. What happens in NPH? Unfortunately, amyloid monomers are not useful in differentiating Alzheimer's or in predicting Alzheimer's from NPH. And why is that? Because in NPH also amyloid monomer levels go down in the CSF. So you may ask, why does that happen? Why should that happen? Because if there is no Alzheimer's, why do the fluid biomarker levels of amyloid go down? And it has very low value in differentiating it from Alzheimer's disease. And we know that AD biomarkers can be misleading in NPH. The reason for this is that when there is NPH and hydrocephalus, there's a decrease in the interstitial spaces between the individual brain cells. And so what happens is there is no space left for the amyloid protein to be secreted into the CSF. So because the space is very compressed. So that results in low levels of all the proteins in the CSF. Uh, Shunting. So what happens interestingly, when we do ventriculoperitoneal shunt, it decompresses the CSF spaces. And what happens is that increases the interstitial space. There is more room available for normal circulation of CSF, and then the protein levels can normalize. And so if we wanted to do pre-surgical triage and pre-surgical detection of Alzheimer's, it would not be useful to look at isolated individual amyloid monomer levels. What would be more important is we also do phosphotau levels and total tau levels. So interestingly, tau levels are more helpful in differentiating Alzheimer's and NPH in the CSF. And we know that the tau levels in Alzheimer's will be increased more than NPH. And so if we also used a ratio of phosphotau or total tau to amyloid beta, if we use that ratio would be more elevated in Alzheimer's disease compared to NPH. And therefore, the message that I want to relay here is that it's important to do combination biomarkers, or it's important to take amyloid and tau levels together, or it can be more helpful in looking at ratios of tau to amyloid instead of just amyloid monomers alone, which can be misleading. Interestingly, there have been some studies where they have seen that this ratio, this prediction of amyloid in the CSF can also predict the response on TAP testing. And people who have this additional Alzheimer's can have a poor TAP test response. Let's look at some insights from biopsy-based studies. And I have cited one important example. This was published in 2016 in the Journal of Neurosurgery. And what the authors did, and this is one of the last biopsy-based studies, because since after that we came into the biomarker era. And so we had CSF biomarkers, and now we even have blood biomarkers of Alzheimer's. So that was one of the last histopathological studies in vivo, where took uh, they took a biopsy from the shunt insertion site, and then they checked for Alzheimer's pathological changes. And what they found is that almost one fourth, that is 24% of all the biopsied patients, had in fact histopathological changes consistent with Alzheimer's disease. And they also found that those who had these Alzheimer's changes had a poor shunt response. So there was a statistically significant difference in shunt responsiveness between the groups of NPH with Alzheimer's and NPH without Alzheimer's. Furthermore, they also found that if the plaques were high density, so if there was a higher density of Alzheimer's plaques in the brain, they had a proportionately lower response to CSF shunting procedure. So really, this biopsy-based study showed a high prevalence of Alzheimer's copathology. Almost one fourth of patients had copathology, and they found a significant correlation between the presence of this comorbidity and the shunt outcome. And therefore, what the author suggested that please do a biopsy when you insert a shunt so that that can help you prognosticate better. Now, that's no longer, this suggestion is no longer valid because now we have CSF biomarkers. When the authors did this study 10 years ago, the CSF biomarkers were not very commonly available. And therefore, they suggested doing a biopsy routinely for all NPH patients undergoing a shunt. However, I do think that this study is very important because it provides the foundation, or it provides the rationale for the further biomarker-based studies that have later come up over the last 10 years. The other important limitation that I want to highlight here is that this study suffered from a sampling bias. So there was a single frontal cortex sample taken during the shunt. And so we know that uh, frontal lobe is not the typical site for Alzheimer's. It is medial temporal, cingulate, medial parietal. So although this was not the ideal site, even then 25% had Alzheimer's. So I think that would be the lower boundary, or at least we can say that at least 25% would have Alzheimer's. The real prevalence, the true prevalence, may be even higher if we looked at other regions of the brain that would have been missed by this biopsy. So I think this is a very important foundational study. And then if we look at some of the newer studies, of course, they are done in smaller groups of people using amyloid PET scans. So we know that amyloid PET scans are the most important, most definitive way of visualizing amyloid in vivo. So when you inject with a fluor beta ben or fluor beta peer, which is the amyloid tracer, all the plaques will take that tracer up, and that will show up as significant on the amyloid PET scan. And there were a few studies that examined whether amyloid PET can predict a response to a TAP test. And in fact, we found that there was a high percentage of people, almost one fourth again, 22.6%, had positivity to fluor beta ben uptake. And so this is consistent with the findings of the biopsy study, where almost one fourth patients have this prevalence of Alzheimer's pathology. And very interestingly, uh, look at the sentence I've highlighted in red. The two groups did not differ in their imaging characteristics. So all of these patients had NPH-like features on the MRI scan, while one fourth of this had amyloid positive, like that is Alzheimer's present. However, their imaging findings did not differ, and therefore that makes us wonder: can we accurately differentiate Alzheimer's and NPH, or if there is an actual overlap between these two entities? Because it's hard to distinguish by MRI scans alone. Also, this found that those who were amyloid negative or fluor beta ben negative had a higher percentage of tap test response and showed a greater improvement in gait scores. So it really affects the tap test outcome. And if there is Alzheimer's present, it can reduce the response to tap test. And therefore, the author suggested that amyloid PET scan should be used pre-surgery to discriminate who will benefit from surgery and who won't benefit from surgery. Finally, let's look at the postmortem studies. And I've highlighted again one important systematic review of autopsy-based studies, which, if you look at all the changes that are seen in NPH, including cortical atrophy, meningeal thickening, NPH-like features, we can see two important findings. Focus on the lower two rows, vascular changes. So almost 76% or three-fourths of the patients had significant vascular changes in the brain. So now we think that vascular and NPH can go together. Also, look at the prevalence of Alzheimer's across the studies. There's in one study that's 48%, so almost half of the people at autopsy have Alzheimer's changes. In some other series, that it's almost as high as 89%. So almost all patients who had NPH had Alzheimer's changes on autopsy. So um, what causes the discrepancy between amyloid PET or biopsy-based prevalence of 25% and the autopsy prevalence of 48% and as high as 90%? So why is Alzheimer's so common on autopsy compared to cross-sectional studies during life? And I think my explanation for this is that the postmortem exam will invariably show late stage findings or advanced findings. So I think at some point in time, these Alzheimer's changes develop during the course of the disease progression in NPH. And by the time that patient passes away and the autopsy is done, they have accrued these changes over time. So they have developed these changes progressively. Maybe in year one of diagnosis, they don't have it. By the time they pass away, if it is year 5, year 8, year 10 of diagnosis, They have developed these changes over time, and so it's only a matter of time that they will develop this neurodegenerative change. And therefore, I think the autopsy study further supports our hypothesis that these disorders go together. And it makes us wonder, is all NPH neurodegenerative? So, is NPH even a separate entity, or is NPH a pre-clinical feature of something like Alzheimer's syndrome? Or do Alzheimer's and NPH exist on a continuum where each can manifest in their own ways, and sometimes they can go together? Sometimes NPH precedes Alzheimer's, and sometimes Alzheimer's precedes NPH. So, is there that kind of interaction between these two disorders? There are some studies, especially from more advances in visualizing the glymphatic system. So we know the glymphatic system is important to clear toxins from the brain, and the glymphatic dysfunction is a common pathological factor between both Alzheimer's and NPH. Why we think that NPH can even be a risk factor for Alzheimer's is that we know there's reduced clearance of CSF, the CSF circulation, and NPH is impaired. And what that can result in is stasis of the CSF. And whenever the CSF becomes really stagnant, there's impaired clearance of toxic proteins. So it will increase the accumulation of amyloid, it will increase accumulation of tau, it will increase accumulation of alpha synuclein, the Parkinson's protein. So really, we think that NPH can also be a risk factor for later development of neurodegenerative disorders. With this background about this overlap and distinction between Alzheimer's and NPH, let's look at two common clinical case scenarios, and then we can open the topic for discussion. So I will present this first case, and why I said that not all patients follow the textbook is this case is an example of the same. So this is a 78-year-old woman, right-handed, who worked as a sales manager. She lives with her husband. She presents with symptoms of 4 years. Her initial symptoms was gait problem. So she had some gait instability, but it was very mild. She was still able to ambulate. But over the last 1.5 years, she has become progressively slower. And so she uses a cane to walk. However, she hasn't had falls, and she denies any Parkinsonian symptoms like stiffness or tremors or postural instability. She denied all of those symptoms. Now, in addition to this gait problem, she also reported some mild short-term memory problems. So some forgetfulness, the husband has noticed some forgetfulness. It is not affecting her activities of daily living. So she doesn't have dementia yet. She only has mild cognitive impairment. And in terms of her past medical history, she also has a lot of vascular risk factors. So she has type 2 diabetes. She has arthritis in both of her knee joints, so that can confound some of her gait slowness. And she had a heart attack in about 25 years ago. So there is a significant background of vascular risk going on. She also was a chronic smoker, and she's quit smoking after the heart attack. She does not consume any alcohol. So based on this presentation, what are the possibilities that come to our mind? So does she have Alzheimer's disease? So because she is reporting some short-term memory problems, we know that people with Alzheimer's disease, they pass through a spectrum with some subjective complaints, then they progress to the stage of mild cognitive impairment, and then dementia comes later on. So is she in one of the prodromal or preclinical pre-dementia stage of Alzheimer's? So does she have mild cognitive impairment due to Alzheimer's disease? Or does she have vascular cognitive impairment because she had the heart attack, she has the diabetes, she was smoking for most of her life, so she has all those vascular risk factors. So does she have small vessel ischemic changes in the brain that can explain her cognitive symptoms and her gait problems? So sometimes people with extensive small vessel changes can have lower body Parkinsonism, or they can have gait dysfunction. So does she have small vessel disease? Or does she have a mixture of Alzheimer's and vascular? We know that pure pathologies are very rare, and most people have a little sprinkling of this, a little sprinkling of that. So does she have a combination of Alzheimer's and vascular cognitive? So those were really my differentials. But I was really surprised when I looked at her scan. So if you look at her scan, and I've displayed the coronal section, which we can see the middle image here showing a very narrow callosal angle. And we can see also there's a focal sulcal outpouching. You can see this focally dilated sulcus here. And another one at in the sagittal region, in the vertex, we can see this focally enlarged sulcus. We can see how the temporal horns of the lateral ventricle are dilated. We can see how the sylvian fissure is dilated. If you look at the image on the right side, we can see the enlargement of the sylvian fissure. But we see some tightness of the high convexity, although not very convincing, may not be as convincing as some textbook images, but we still see this high convexity tightness relative to the sulci lower down in the brain. So really, is this scan shows NPH-like features. And if we look at the axial sections, we can see how there are focally dilated sulci, there is some crowding at the vertex, and there is ventriculomegaly as well. If we take the diameter of the sylvian fissures, it is 9 millimeters. And we know that more than 6 millimeters is considered as elevated. So if we did this DASH scoring, which is a radiological parameter we use to score NPH, we know there's elevated Evans index, there's a narrow callosal angle, there's elevated diameter of the sylvian fissures, there's a tight high convexity, and there's focal sulcal dilation in two places. So really, she scores 10 out of 10 on DASH. So if we were blinded to the clinical outcome, if we just looked at the MRI, the MRI would fulfill radiological features of NPH. So if I was a radiologist reporting the MRI, I would say there are features of NPH on the MRI, please correlate clinically. And that all so familiar sentence, please correlate clinically, becomes really important in this case because the clinical picture is not very typical of NPH. There's a mixture of findings. There's some memory complaints, there is some gait complaints, but then there are a lot of confounders. So she has arthritis, she has the small vessel ischemic changes. So how do we dissect out which is which? And this is where your neuro exam becomes important. Does she have those hard signs of higher level gait disorder? Does she have the freezing of gait? Does she have gait apraxia? Does she have those difficulty making turns? Does she have freezing? So all of those hard signs of NPH, are they present? Or is it more non-specific gait dysfunction that can localize to other parts of the neuroaxis? Or does it localize to even non-neurological regions? And therefore, she was first assessed in the movement disorders clinic a couple of years ago. And the movement disorder specialist, Dr. Mandar Jog in London, he concluded that there were no conclusive features to suggest NPH-like syndrome, whereas her MoCA test was 20 out of 30, and she lost points across the board in visuospatial, in attention, in memory. So really, they thought it is primary cognitive syndrome and not NPH clinically. And then therefore, she came to our memory clinic. When I saw her very recently, I saw her a couple of years after the initial movement disorders assessment. Her gait instability had worsened. So her gait had become wide based. The family had noted a wide based stance, and she had one fall and many near falls where she was very unstable and she had to hold on to something to prevent a fall. And then her neuro exam now showed a wide based gait that was not noted in her first presentation with some turning difficulty. She also needed a lot of support to rise from the chair. However, she didn't have gait apraxia. I agreed with that note. We also did some cognitive testing, which showed impairment across the board. So we use this neuropsychological test called Toronto Cognitive Assessment, which is almost like a mini neuropsychological battery that tests different domains of cognition, including memory, immediate as well as delayed recall. We also do a number of tests for visuospatial function. We also do the recent memory for both list learning as well as for images. And so her cognitive testing indeed showed impairment, not only in the working memory and attention. So there was impairment in working memory, attention, executive function, but also in the memory part. So really, this showed a mixed feature that we can see in Alzheimer's disease. So Alzheimer's disease can present with amnestic multi-domain cognitive decline. So if I only look at the cognitive testing, this can very well be a person with Alzheimer's disease. But now with this additional knowledge that her MRI was NPH-like and her exam showed some progression of the gait-related symptoms as well, not just cognitive. So really, where do we land with this? So is her diagnosis NPH? Is her diagnosis Alzheimer's? Or is her diagnosis mixed NPH Alzheimer's? And or is her diagnosis NPH plus vascular cognitive impairment plus Alzheimer's? So does she have all the three? And I think she has all the three with some contribution from each of them. And this case highlights the important overlap that we see commonly in clinical practice. And not all patients have a pure isolated syndrome. Many people have this kind of overlap. So really, I don't have the final answer for this patient. So my plan is I will do a lumbar puncture and do a CSF drain because she had the gait impairment. If she did not have the gait impairment, if she had only cognitive, my plan would be just manage along the lines of dementia and not and leave her alone, not do the CSF tap test. Because her gait has worsened and it's turning out to be more NPH like with the wide base and wide base and falls, I'm planning to pursue the NPH management. So these are some of the overlap scenarios. The last case, final case I'm presenting, another case here. I'll start with the scan first. So if we look at this scan, this is another scan which shows typical NPH features. So if you look at the bottom right figure, you can see how this crowding of the sulci at the vertex. We can also see the dilated ventricle. We can see the thinned out corpus callosum. We can see focally enlarged sulci. We can see the dilated sylvian fissures, and we can see ventriculomegaly, and we can appreciate the acute callosal angle. So really, another person with a DESH score of 9, so almost checking off all the criteria for NPH on the scan. Can you guess what this patient had in terms of clinical symptoms? So did this patient have NPH? In 2021, 5 years ago, when this patient first came, he had no clinical symptoms. So this was an incidentally reported finding on MRI, where the radiologist said there are imaging features of NPH correlate clinically. Clinically, the patient had no symptoms at all. And therefore, the neurosurgeon who assessed him said that currently he does not fulfill any criteria for clinical NPH, and therefore we should leave him alone. However, if he starts developing symptoms during his life, then he should come back for a reassessment. So, what is this condition called? I think this is called preclinical NPH or AVIM, where AVIM stands for asymptomatic ventriculomegaly with features of idiopathic NPH on MRI. So this is has been described in the Japanese papers, where we think that NPH is a chronic hydrocephalus, so it doesn't happen overnight, and we know that symptoms do not appear overnight. So there can be a long preclinical phase for NPH, just like there is a long preclinical phase for Alzheimer's, where we know that the amyloid is accumulating, and at some point the balance tips and the people develop cognitive decline. Similarly, it is possible that NPH starts out as a radiological syndrome with a long delay, and at some point people go on to develop gait dysfunction. So this is the preclinical stage of NPH, and it has been reported in literature, AVIM, in the Japanese population, almost 6% of all the 70-year-olds, so they did a population-based prospective study where they did imaging for 70-year-olds, and they found that 6% of people had prevalence of elevated Evans index. And some of these people later, they followed them up for 4 to 8 years, and about 1% of these people who had ventricular expansion went on to develop NPH-like syndrome or dementia. So really, the NPH can have a it can be an incidental finding on some of the imaging studies that are done for the purpose. When I saw, interestingly, and this is where the twist lies, when I saw the patient 5 years later, early this year, he did not have any gait changes. So really, gait was very fast, narrow base, normal stride length, normal speed, normal turns. So everything was essentially normal about his gait. So what did he have? He had cognitive changes. So he had short-term memory loss, which was progressive. It had started affecting his instrumental ADLs. His memory has declined very fast, and now he's repeating questions, forgetting conversations. He's mixing up dates and appointments. He needs reminders to complete his self-care tasks, occasionally even agitated. So really, this patient has evolved to Alzheimer's dementia and is presenting with a typical moderate dementia stage related symptoms. When I did the MOCA for him, it was 20 out of 30, and his memory score on the MOCA was very poor. It did not improve with queuing. So really, all the cognitive testing and his clinical presentation supported a diagnosis of Alzheimer's disease rather than NPH. And so this really highlights the fact that NPH can be NPH-like presentations can be one of the early signs of neurodegenerative disorders. So this is someone who started out looking like NPH on the MRI scan, who did not have any clinical signs of NPH. And over the course of 5 years, this person developed Alzheimer's dementia rather than NPH. And so again, ventriculomegaly as a sign of early neurodegeneration. And this has been reported, published in the Annals of Neurology 2017. And it's a very important diagnostic consideration that we should not miss, and we should not be committing. Why I highlight this case is that we should not be committing these cases to work up for NPH And we should not give them a false hope that NPH interventions are going to improve anything, because these people do not have NPH. They have a neurodegenerative disorder that is unfortunately going to progress. And so it's really important to recognize these mimics of NPH, and these avoid any misdiagnosis. And so I'll come back to the first Venn diagram where we showed, are they two separate entities? Is there an overlap? Do they overlap more than we can expect by chance? Or are they one and the same disorder? So I think it's the third option. I think they overlap more by chance. There may be a few people in whom they can have isolated NPH, but that's really rare. The other important thing to remember is not all patients who have radiological NPH have the clinical symptoms. And if they have a clinical syndrome, I would really look for the gait dysfunction, because it is the gait that improves post intervention. So from the triad, if they only have urinary or if they only have cognitive, really I wouldn't bother subjecting them to the lumbar tap test and shunt surgery. So that's the key take home message. Not all patients, even with clinical and radiological features, they benefit from shunting. We know that Alzheimer's very commonly accompanies NPH and may develop over the course of NPH. Other neurodegenerative disorders like Lewy body, Parkinson's have also been reported in overlap with NPH, and that's because of the CSF stasis. There's going to be accumulation of different toxic proteins. So it's not just Alzheimer's. Sometimes other disorders like Lewy body dementia can also develop in someone with NPH-like features on the MRI scan. And so we know that the interaction between NPH and AD is complex, and the presence of Alzheimer's can affect long-term outcomes. And so it's very important to consider this comorbidity in prognosticating NPH patients. So proposed roadmap. And so the challenge in NPH is there are no long-term follow-up studies that have properly characterized these NPH responders and non-responders. So really it would be important to see long-term, like more than 3 years. There are lots of studies that have a study duration of 3 months or 1 year. But how do these people respond at 2 years, 3 years, 4 years down the road? And how many of them develop Alzheimer's disease? So that would be really important going forward to gain more knowledge about this interaction between Alzheimer's and NPH. So I will stop here, and I'm happy to take any questions regarding this. Thank you very much.
Thank you, Dr. Amay Patwardhan. It was a wonderful, comprehensive talk on NPH and Alzheimer's disease, and I'm sure that the listeners and there are about 90 people who have learned from you. So I'll request Dr. Ella to now take over and summarize.
Thank you, Amaya. It was really an enlightening talk. So for the starters, it seems like NPH is like a treatable disorder, so you should never miss them. So generally, there is a tendency to sort of do the CSF tap test with a very low threshold. So what would be your take on that? In the meanwhile, I'll also ask the participants to put their questions in the chat box.
Sure. Yeah, thanks for the question. I think that's a very important question and clinical dilemma. I think NPH is over suspected because we conceive it as treatable. So, like I mentioned, we should look at the clinical syndrome, and if someone has the gait dysfunction that is typical of NPH, then 100% we should do the CSF tap and give them the benefit of doubt and see if that helps. I would suggest that although it's too early to have, we don't have conclusive evidence to show that because there's no long-term studies, but I would subject that CSF to Alzheimer's biomarkers to see if, and then follow up these patients. I'm not saying right now that we should exclude people who have Alzheimer's from shunting. So we can still shunt people who we think had a response to the TAP test. But I think it can be important to store that CSF subjected to biomarkers, and in the future, see their long-term prognosis, because those are the kinds of studies that are going to tell us if we should be doing it more routinely in all patients.
Thank you. And does your university take samples for biomarker analysis? Like, do you have a validated lab?
Yeah, that's a good question. So we do Alzheimer's biomarkers through research. So we do have both clinical grade and research grade assays, and we are planning to do a CSF biobank as well. So all of these CSF samples will be stored and they can be tested for future biomarkers, not just Alzheimer's, also alpha-synuclein and other biomarkers of degeneration, maybe neurofilament light chain, whatnot. Because I think this is a precious resource that we have. So much of high volume CSF we're going to drain. So why not store it and subject it for future studies? Um, I can see a question in the chat. I think someone has asked if there's no clinical symptoms but radiologically NPH, how to treat. So I briefly alluded to this, that it can be an incidental finding, and I think there is no pressure to treat the scan. And like I tell my patients, we don't want to treat your scan, we want to treat the patient. And so even if there is NPH on the scan, I think it would be very prudent to do a follow-up of this longitudinally to see if NPH evolves into clinical syndrome or not. And so at the early signs of clinical symptom development, we can intervene. Until then, it can be watchful waiting, as we call it.
A few more questions as well. Uh,
Yeah,
Ria has asked if there is NPH suspicion and if patient improved after CSF, is it enough to prove if a patient is not cooperative for MRI brain, despite safest dose of sedation?
usually, typically, patients with NPH don't have agitation, or they usually should not have this kind of behavioral symptoms. So, if someone has behavioral symptoms and they're not cooperative for MRI, one should wonder: are we dealing with something neurodegenerative? Like, why is this patient so behaviorally impaired that? And how did they cooperate for the CSF tap if they are not cooperating for the MRI? So, I find that a bit counterintuitive.
Maybe I would maybe paraphrase the question like, is a CT sufficient or is an MRI required as per your experience?
Oh, that's a good. I think there is no compulsion for MRI if CT would suffice, because we are going to see most of the features we need to on the CT scan.
So I am not sure if Ria meant the patient had behavioral issues. In that case, Amaya feels that maybe the patient has some other frontal issues, or maybe is it really NPH? Or otherwise, if the patient is just claustrophobic and did not want to get an MRI, maybe a CT can be done as an alternative.
Right.
And
Yeah.
Karthik has a question. You gave a
Yeah. So
hypothesis that CSF stasis leads to a neurodegenerative pathology. Could it mean that if we treat the stasis with shunting early on, we could delay the neurodegeneration?
I think that's a great question, and I think we should think in this direction. I think you're thinking in the right direction, but I don't know, because all of these biomarker-based studies are so new. Like, we don't have this kind of longitudinal data to see what happened, and that's why I said we should not remove all these patients from. We should not. It should not preclude shunting. So even if we find early amyloid, maybe we can shunt, and over the long term, we should see what happens to these patients. Do they develop dementia or not, and are we in fact delaying it? So we know that I mentioned that after the shunt, some of these markers can be corrected in the CSF. So amyloid levels that were low, in fact, go up because there's decompression of the interstitial space. And therefore, I think it's a very interesting thing. Long-term follow-up studies will give you the answer.
So yeah, I would also agree, and we also have been working on normal pressure hydrocephalus. And as Amir rightly said, the presence of like Alzheimer's pathology is not a contraindication to shunting. And we found that in our cohort of patients, like shunting led to a 10 times higher odds of a good improvement. So if you feel that the patient has a triad and rest of the features are fitting in with NPH, based on the available evidence and the current RCTs, I think it is a prudent idea to proceed with shunting rather than denying that benefit to the patients. Thank you.
I will
And
agree.
Harshal,
I think I will add to
sorry,
that,
go
though. The
on.
triad, I think the gate would be really important, because without that gate dysfunction, there is no meaning to the triad. And there's no, even the RCT that was published in JAMA showed that cognitive outcomes did not improve, even in the short term. So really, if the triad has missing gate, we should not do anything.
Yeah, there is I think in 2015 there was a study published in Lancet as well, the Symphony 2 trial. In that study
Right.
also, gait is the one, the MRS is the
Correct.
main outcome parameter that
Correct.
they had studied.
Correct.
And
Correct.
Harshal wants to ask if you could share your PPT.
Sure, I'm happy to. I can send that.
Okay,
Um,
maybe Asmita, you can coordinate with Amey and get the PPT and maybe send it to all the attendees who had attended.
yeah, I'm going to drop my email ID in the chat because someone is asking for it. So if anyone wants to reach me, they can contact me on my email here.
Thank you. Thank you so
Great.
much, Ameya. Thank you for
Very
this
good.
effort
Thank
early
you,
in the
sir.
morning on a cold morning, I'm sure.
No problem. My pleasure, and thanks for inviting. It was a great experience. Okay. Bye
Okay.
for now.
Thank you.
Take care.
Thank you. Thank you, Asmita. Thank you, entire
Thank you,
digital
Dr. Ame,
team.
and thank you, Ella. And thank you
Thank
all
you,
the
sir.
participants for logging in and getting this important webinar, attending this. Thank you once again. And we look forward to see you again in the second week of March.
Thank you. Thank you, sir.
Thank you. Bye-bye.
Bye-bye.